Hello, everyone. My name is Radwa. I did this week's presentation on SIADH. So for the disease process, the antidiuretic hormone, ADH, is produced by the brain's hypothalamus. It is then stored by the pituitary gland and released when necessary via the negative feedback process. Normally, this hormone helps the kidneys by aiding in the conservation of the correct amount of water within one's body. It also helps the body correct any detected abnormal fluid loss by retaining more water as well as preserving a healthy blood pressure. Problems arise when the pituitary gland releases an excessive amount of ADH hormone. SIADH is a result of an increased level of the production of ADH within the body. SIADH is responsible for a combination of ADH-induced water retention as well as secondary solute loss. Due to the shift of the water, it will lead to a low sodium level in the blood, which is seen when the serum sodium concentration falls below expected normal ranges. This causes hyponatremia, which is a major complications, and it is responsible for many of the SIADH symptoms. A few of the earliest clinical manifestations of SIADH during an acute hyponatremic phase are nausea and malaise. In more severe cases, patients can become increasingly confused, experience seizures, or coma. As part of the diagnosis and treatment, providers will limit one's fluid intake to prevent further buildup. Additionally, the goal of treatment is mainly the correction of any underlying abnormalities, if any are present, such as hypothyroidism or pulmonary or CNS infection, as well as correcting the sodium level. The goal for sodium correction is to be higher than 130 MAQs per liter. The normal level of sodium level is 135 to 145. To correct the low level of sodium, 3% hypertonic saline is used. The rate should not exceed more than 8 MAQs per liter within 24 hours. The rate of correction is an important factor. Correcting the level of sodium at a fast rate could cause CNS changes as a result of fluid shift. Rapid correction causes osmotic demyelination of CNS. This can lead to severe lethal complications such as osmotic demyelination, locked-in syndrome, causing quadriplegia. For the pathophysiology, the antidiuretic hormone is also known as vasopressin. It's formed in the hypothalamus and stored in the posterior pituitary. The most important and primary function of this hormone is osmoregulation. It helps control and balance the homeostasis of fluid. Any alternation in the fluid balance, the osmoreceptors detect the change within the hypothalamus. Vasopressin release is then stimulated due to the increased plasma osmolality, decreased blood volume, or decrease in blood pressure. An acute drop in blood pressure causes the release of ADH release, along with other hormones such as renin and epinephrine. These hormones generate free water absorption from the kidneys. As a result, the hormone increases water reabsorption in the distal nephron, producing concentrated urine and diluted plasma. This can potentially lead to hyponatremia and a decrease in effective CF osmolarity. As a result, this causes the water to move into cells, causing cerebral edema. In patients with SIADH, vasopressin release is inappropriate in the presence of normal or low plasma osmolality and normal or high blood volume and blood pressure. In such cases, the water is inappropriately retained by the kidneys and ultimately causes euvolemic or dilutional hyponatremia. In other words, the total body sodium, as well as the extracellular fluid volume, are normal or near normal. However, the total body water is increased. SIADH can also be hereditary. A mutation in the genes that is located on the X chromosome for the renal vasopressin 2 receptors is responsible for the hereditary SIADH. Such mutations lock the renal vasopressin 2 or V2 receptors in a continuous active state, leading to excessive water absorption and hyponatremia, which in turn is resilient to any vasopressin receptor antagonist. For risk factors, SIADH can be hereditary. It's called nephrogenic SIADH, which is caused by a mutation in the vasopressin 2 receptors within the kidneys. Additionally, SIADH occurs most commonly as a secondary to another disease process or conditions. SIADH is more prevalent in individuals with a longer duration of hospitalization, particularly among the elderly, as well as children who have been hospitalized for either respiratory, CNS infection, by opportunistic pathogen, such as pneumonia or meningitis. There is a higher incidence of SIADH in individuals who are diagnosed with a tumor, such as small cell lung cancer. Post-op patients are also at risk due to the administration of hypotonic fluids during the surgical procedures and the body's response to stress. It could always be stress. SIADH can also be induced by the administration of exogenous hormones. For example, medications are used in ICU settings, such as vasopressin, in order to control GI bleeding, desmopressin to treat platelet dysfunction or hemophilia, or von Willebrand disease. Oxytocin is heavily used in maternity wards to induce labor. All these medications act by increasing the activity of vasopressin 2 receptors, potentially causing secondary SIADH. Any CNS abnormality will increase the incidence of leading to SIADH by enhancing the EDH release from the pituitary gland. Examples of CNS disorders include mental illness, psychosis, hemorrhage, stroke, trauma, or infection. SSRI medications, carbamazepine, chlorpheniramide are a few of the most common medications that are associated with SIADH by increasing the sensitivity to ADH, increasing its effects of ADH, and enhancing its release from the pituitary gland. Ecstasy is a drug of abuse. It is particularly associated with the direct release of ADH. This drug worsens hyponatremia as it further stimulates one's thirst. Hyponatremia is a common laboratory manifestation that is typically seen in individuals who have early symptomatic HIV infections or AIDS. SIADH can occur as a result of hyponatremia or volume depletion, secondary to other conditions such as GI losses or adrenal insufficiency. Disorders such as hypopituitarism and hypothyroidism are also accompanied by SIADH. Picture symptoms include hyponatremia. For major signs and symptoms, patients present with clinical manifestations of SIADH, same as those with hyponatremia, as well as the effects of a decreased ECF osmolarity. As a result of fluid shift, it causes the water to move into the cells, resulting in cerebral edema. The individual's presenting symptoms depends on the level of hyponatremia, as well as the severity of the cerebral edema. Symptoms can be subtle and consist mainly of changes to one's mental status. The earliest recognizable clinical manifestations of hyponatremia are seen when the serum sodium concentration falls below 125 to 135 MEQs per liter. An individual will complain of nausea, malaise. Additional symptoms include vomiting, which is an ominous sign for patients with acute hyponatremia. With a further acute fall in sodium concentration below 124, patients will become lethargic, complain of headaches. Symptoms may progress to being obtunded, and eventually seizures can occur. Serum sodium level below 115 can cause neuromuscular hyperaccessibility, hyperreflexia, stupor, coma, and even respiratory arrest. Symptoms are reversible if the underlying cause, as well as serum sodium level, is corrected. If left untreated, acute hyponatremia encephalopathy may cause permanent neurological damage or death can occur. Therefore, a detailed neurological examination, extensive knowledge of one's past medical history, as well as a detailed physical examination are essential. Lastly, SIADH is more common among the elderly populations, ages 65 and older, with advanced age. Mild to moderate levels of hyponatremia may contribute to fractures, placing them at a higher risk of falls, in addition to gait problems. For diagnostic testing, there's no single best test to aid in the diagnosis of SIADH. Due to its diverse etiologies, diagnoses should be pursued based on individual symptoms and signs. It is quite challenging to successfully diagnose SIADH alone without inquiring about other conditions, in which includes a history of potential head injury, chronic pain, certain prescribed medications, or substance abuse, including heroin or ecstasy, in addition to all of the above-mentioned symptoms. Further assessment, tests, and labs are required to find out any underlying causes according to the patient's medical history. Patients with long-standing smoking history, weight loss, or preliminary symptoms must have a chest X-ray and CT scan to look for possible tumors, such as SCLC. Clinicians must rule out other etiologies, especially for individuals who are taking prescription medications. The clinician should evaluate the patient for hypothyroidism or adrenal insufficiency before diagnosing the patient with SIADHD. Lab tests should include serum and urine osmolarity, electrolytes including potassium, bicarbonate, chloride, urine sodium concentration and osmolarity, BUN and creatinine, liver function test, thyroid profile, serum cortisol, fasting lipid profile. Also, random blood sugars as well as renal function tests to evaluate for potential hyperglycemia and uremia, as these patients are the potential causes, these are the potential causes for pseudo hyponatremia. To aid in the diagnosis of SIADH, many providers use the Brader-Schwartz syndrome as a clinical criterion based on the individual's lab results. Patients usually present with serum sodium that's less than 135, urine sodium that's greater than 40, serum osmolarity that's less than 275, urine osmolarity that's greater than 100. Furthermore, using the method of temporary correction of hyponatremia by fluid restriction in order to evaluate one's response is also part of that criterion. Providers diagnose patients with SIADH in the absence of clinical evidence of volume depletion, which includes signs and symptoms of having normal skin turgor and blood pressure that is within reference range. Providers are also able to diagnose SIADH in the absence of other conditions and disorders, which can cause hyponatremia. Lastly, central nervous system imaging is reserved for patients in whom a brain disorder is clinically suspected or other causes of SIADH can be found. Thank you so much for listening. I hope you learned a lot from my presentation. Thank you so much.